Other questions, which I will try to give an answer to. Yesterday, some of you have heard the basic approach, and it is displayed here, and you have it on the handout. You will also find this on our page. So, I will go through these questions, and you will see some of the same slides as yesterday, but not. But there will be more examples. So, what is behavior change and how is behavior change related to the water and sanitation sector? And this is basically the interdependency of software and hardware, as I explained yesterday. So, hardware without software does not change. Of course, it does change a bit, but hardware with software, this I will show you once more, is more effective than hardware alone, and software without hardware, nearly nothing. Why is the consideration and integration of behavior change a promising and necessary approach for the water sector? You remember this picture, but summarized, it means that the hardware might not be used at all, or badly used, or misused, or maybe will pose a risk. So only constructing toilets in schools. I presented you yesterday this article, and what we see many times in the consumption of disinfectant water without compliance, constant high use, there is no health effect. If people drink 50% raw water and 50% disinfected water, no effect. Like that. What is the advantage of evidence-based behavior change, and what is particular unique for the approach? Well, as we first have this baseline, we have different outputs from the baseline. First, what the population has. Do they still open defecate? Do they have latrines? What kind of improved toilets do they have? Do they have hand washing stations or not? Then what the population does. Do they use the hardware? Do they hand washing before handling food or after going to the toilet? And how is it about the general hygiene behavior? Are the kids clean? Are the nails clean? And so on. And then, as I explained, and that's the core of the model, what the population thinks. What is the knowledge about getting diarrhea, for example? In what kind of beliefs do they have? What feelings arise when they think of the behavior? What values is hygiene important value for them? And we can also reveal the biggest deficits in hygiene. Which behavior change will have the biggest impact on health? This we can also reveal. This we will gain from the baseline outputs. One example where I presented it already yesterday, where do Kampalas Pur go? You will find that also on our webpage. This was a study. This was a study with 1,500 sample households in 50 different slums in Kampala. And what did we, some results from this baseline, for example, satisfaction with the toilet time, or whether the toilet is perceived as clean or not, and what kind of problems do people have with the toilets. One example. Then going on, show it here. For example, this one, among shared and public toilet users, one stance is on average used by 30 individuals or 7 households like that. Or only 47% of sanitation facilities are clean enough to be used properly. And 45% of sanitation facilities are abandoned after 5 years because they are full and broken down. So these are results we generate with this quantitative baseline approach. It is representative for the target population. 1,500 is a good number. Is not subject to researchers' preferences. You know, qualitative research somehow reflects, or sometimes reflects, what the researcher thinks. And we have clear-cut results. As we said to you yesterday, we compare the doers with the non-doers, the performers with the non-performers, and we do that statistically. Moreover, the approach pinpoints which behavioral factors are to be changed. We know exactly what to change. And this minimizes monetary costs, of course. But it also minimizes social costs. If you think of CLTS, I don't know who knows of CLTS, but it works with shame. Yeah. So people point at others who they have seen that they still do open defecation. They say, shame on you. And I don't know what the social costs of this are in a small community, for example. And it optimizes also the strategy. The foam approach, this is focus, opportunity, ability, and motivation, does not say which behavior change strategy targets which factor. But this you see on the table on the right here. And it minimizes necessary know-how. So CLTS is a rather, let's say, difficult procedure, but we don't need that. And it maximizes sustainability because at the end we introduce habitual behavior. And it maximizes behavior change effects, which I will show you with the next example. This is research on arsenic in Bangladesh. Many millions of people are at risk with arsenic, and you cannot treat it somehow. So prevention is very important. Well, testing was done and awareness was raised so far, but there are many people who have the possibility, who have the access to arsenic safe wells, but they don't use it. Okay, what did we do from our baseline research? You see that commitment, descriptive norm, and the self-efficacies are the most decisive factors, the factors which differentiate between the users of arsenic safe wells and the non-users of arsenic safe wells, although they have access. Good. First group, that's our control, because that's what mostly is done by NGOs, is education, information, risk information. Then we work with reminders, which would go on commitment. You see before your kalosh, that is the water storing and water transport vessel, is empty. Go to collect water for drinking or cooking from the name of the neighbor. Green shallow tube well, the one who is arsenic free. And this is posted nearby the location of this station. And we work with reminders where we say what can be done, or how can the water be used when the well is contaminated and when it is not contaminated, like that. So, third intervention, third behavior change strategy is implementation intention. These are where, when, and how plans. So here you have every day after or before, like that, getting up, for example, and after or before having breakfast, and so on. I'm going to Mubarak's tube well. This is the name of a green tube well owner, and I'm going to collect how many of this kalosh, and for drinking and for cooking. And we did a public commitment saying that in this round of women, at the end of this session, we asked who will in the future use only safe water from safe wells. Now, what is the result? Information only, about 11%. New users of same words. Reminders and information, about 30%. If we add implementation intentions, we have about 41%. If we add the public commitment, we have 64-65%. So normally what would be done is information only, but with our evidence-based approach, we can be more effective, 4 to 5 times more effective. We come to costs. We can calculate the costs. Information only, about $1. Reminders and information, $1.7, and so on. And aside here, you see the behavior change effects. These are the percentage I just presented. And at the end, you see that evidence-based behavior change techniques are 4 to 5 times more effective, but only 3 times more expensive. We have to calculate it because all these behavior change techniques need some money. Next question was, what drivers or barriers play a role in their behavioral choices? This is a lot of text, I know, but it's just to show you that these factors here can be drivers as well as there can be barriers there. For example, for action knowledge, that's easy. Person does not know how to perform the behavior. For action planning, person did not make a plan for the performance of the behavior. Or whatsoever, descriptive norm, others' behavior. Person perceives that nobody performs the behavior. These can all be barriers. All these factors are important. So we have to take care of it. If you want to have a kind of steps, if you follow this model, then the first would be inform, persuade, work with norms, supply and train, and help planning. Help planning is mostly forgotten. Then the questions, do we have any evidence to know which interventions really lead to sustained behavior change and why? And can I provide some further examples? Yes, I can. Example 2, our Haiti study on hygiene for watsan America. Here we looked how these different promotion activities influence these factors of the RANAS model and how this then has an influence on the behaviors. Method was a cross-sectional survey with 800 households. And the first result was, for example, how did people rate the convincingness of these different behavior change techniques. And you see, they did a lot, even more than these. And on the not so good side are these focus groups, sticker poster paintings, special hygiene day. And if we calculate, we do that statistically, via trend analysis and mediation analysis, we also, as I presented yesterday, we can calculate the total effects of the different promotion activities here on feces-related hand washing. And you see that song, focus group, and sticker poster paintings are the worst. And with focus groups, we have to say, be careful with focus groups, because if you discuss problems that people have not experienced so far, they will be hesitating to adopt the behavior. Example 3, drinking water in Chuquisaca, Bolivia. You see the situation is quite worse, and you see that on the right side, this is their, for example, one water source they use. They have a high infant mortality. We disseminated their solar water disinfection. I don't know, in a few words, You put the contaminated, bacteriologically contaminated water into PET bottles. You put them in the sun for 6 hours and then you can drink it. Or if it is clouded, for 2 days. What did we do there? We used persuasion, promoters. They argumented on instrumental beliefs. Taste is really good of solar water. It's not time consuming at all. It's not expensive, and there's a health effect. And additionally, we worked on this self-regulation block with this prompt reminders and the public commitment. So, what were the results? First, you see that when we do nothing, and we have at least 10% of, I have to explain that, sorry. We have this is the total consumption of water, of drinking water, and you have solar water, boiled water, and untreated water. And when we apply our interventions 2 times, we have 45% of consumption, of the total consumption is there, solid water. And if we apply both persuasion and reminders, we have even 59% of solar water, that people drink solar water. And most important is this part, that only 14% of raw water are consumed. This boiled water stays constant, and that's good. One more example. Drinking water in Harare, in Zimbabwe. You see, these are displaced person, internally displaced person. And they have even worse situations of their drinking water. And there we use several techniques which we developed from the baseline. You see here a market trial, okay. The NGO invented that. This implementation contract, as I showed you before, promoter visit, this reminders, of course, information events, and we have a pass-on task. Pass-on task means that you get a voucher for reduced priced bottles in the bottle center for doing this solar water disinfection. And if you go to the bottle center, you get these bottles and you get another voucher for somebody else, and you have to pass it to somebody else, and they can come and get it too. So we tested these different interventions in with different areas, and we had a control. And you see what we did in these areas. Here we did not so much, except with the market wire, and here we did nothing. So 9 months, so to say, we have no intervention. And what is the result here? Here we have in the best areas, 1 and 2, you see it here, we have 75 to 85% of these bottles in the sun at baseline. This is observation, it's not self-reported. We go through the community and look on which roofs of the households we find solar bottles. What do I need to know and consider for such an approach? We have developed this behavior change guideline, and there we have these 9 steps. I will not go through. You have possibility to look at our guideline and you can get more information about that. How much time does it take and required resources to implement, and what are the benefits to be gained out of it? So we have we proposed a 3-step procedure. First, this baseline survey, which I talked a lot about. Then this pre-test of the behavior change techniques. We have seen that in the Zimbabwe case. And then the monitoring and evaluation. This is, we do several surveys with the same households, and there we get out how the strategy is functioning, so to say, and what can be changed or should be changed. Or the alternative is that we have a constant engagement of EAWAG for 2 to 3 years, and we do all this in one event, so to say. What are the outputs of the baseline survey? I already said that: incidence of all relevant behaviors, disposition of the behavioral factors in the population, comparison of performers with non-performers, and biggest deficits in hygiene. And duration is about 5 to 6 months, and costs about 50 to 60,000. The pre-test then is a bit shorter, could be also a bit longer. There we evaluate the strategies, and we get out which is the best strategy to use. Monitoring and evaluation. I already said we have several surveys, and we know then how effective are these behavior change strategies. And what we also have to calculate that there are additional costs for an NGO which we train to do these surveys. Each survey costs about, for 750 households, costs about 10,000 euros. This is our experience so far. And also the behavior change techniques will cost something, 1 to 8 euro, I would say, and depending on the target population, then it is more or less expensive. How can an integrated approach in the water and or sanitation program look like? And you see that here, the baseline leads this time, then the pretest, then the monitoring and evaluation. It depends how much time between the implementation at scale and the surveys should be. This can be 2 months, 3 months, 6 months, however the program